Duchenne and Becker's muscular dystrophy. Dystrophinopathies are a group of disorders caused by abnormalities in dystrophin. Dystrophin is a protein important in the complex that connects muscle fibers, actin, to the surrounding extracellular matrix. This complex is important in the movement of skeletal muscles as well as cardiac muscles. So abnormality in this protein dystrophin interferes the function of the muscle in its interaction with the cell extracellular matrix and cell membrane. In Duchenne's muscular dystrophy, the dystrophin protein is non-functional. And again, this dystrophin protein connects the actin filament to the cell membrane. As a result, every time the muscle contracts, it pulls little rips into the cell membrane. Creatine kinase is a source of energy for the muscle cells. When there are rips in the cell membrane, the creatine kinase, or CK, migrates out of the cells. Elevation of creatine kinase, or CK, in the bloodstream is a sign of muscle disease. It's seen in a number of skeletal problems, including many of the different forms of muscular dystrophies. The other problem is that creatine kinase is an important source of energy to the muscle, so depletion of CK in the muscle cells decreases its energy source. While the creatine kinase is migrating out of these small rips, calcium is migrating in. Calcium, when it migrates in, is activating proteases. Normally, this is held in a very close combination of the calcium inside the cell, because when calcium attaches to an inactive protease, it activates it, and proteases break down muscle cells. Over time, these muscle cells are taken over by fat cells, and this results in the clinical phenotype of the calf hypertrophy that I'm going to show you in a second. So, muscular dystrophy, Duchenne's muscular dystrophy, occurs in about 1 in 5,000 males. It's inherited in X-linked fashion, and clinical features include progressive muscle weakness, calf hypertrophy, toe walking, and progressive lordosis. So you can see this lordosis here, and as it progresses as kids get older. Boys are usually wheelchair bound by age 16, and death in the late teens to early 20s, secondary to dilated cardiomyopathy. The heart is the most important muscle in our body, and as the skeletal muscles are weakening, so is the heart. And so a dilated cardiomyopathy is the heart becoming enlarged and it's not contracting correctly. On exam, there's muscle weakness in both the upper and lower extremities. Proximal muscle weakness, more significantly affected than distal. So here are the proximal muscles up here, but you can see this hypertrophy of the calves because, again, the fat is taking over the muscle. Gower sign is actually a sign that we use in looking. It's basically shows this proximal muscle weakness. And I want to show you how this little boy is trying to stand up. Instead of just jumping to a stand, he has to actually walk up his legs. And that is because of the proximal muscle weakness. So we're just going to watch this one more time as he first pulls and then uses his hands to almost walk up his legs. And he never even dropped his stickers, which is a great thing. Becker's muscular dystrophy is also an abnormality in the dystrophin gene. The dystrophin is altered, but some is produced. It has a milder phenotype than Duchenne's, and patients are usually wheelchair bound by their late teens, death between 20 and 40, again because of the dilated cardiomyopathy similar to the Duchenne's. Now, as I stated earlier, the dystrophin gene is located on the short arm of the X chromosome. Males have only one copy of the X chromosome, so if the only copy of the dystrophin gene is non-functional, they don't have any functional dystrophin, and they are affected with, in most cases, Duchenne's muscular dystrophy, but if there's some function to the protein, Becker's. Females, though, it's a little bit more complicated. As I stated, females have two copies of the X chromosome. They have one that works and then one that doesn't. But the problem is in the X chromosome, it's not quite the same as the autosomes. In autosomes, all the cells are active, whether it's the mom's copy of chromosome 1 or the dad's copy of chromosome 1. In the X chromosome, there's something called X inactivation. That's to compensate for the fact that men have this Y chromosome and females have these two big X's. The female X inactivation, in some cells, this cell is inactivated, while in other cells, this cell is inactivated. The problem is, if the X that has the non-functional copy of dystrophin is inactivated, that's fine. We have normal dystrophin in the cell. And so the muscles are happy and everything's working well. However, if this is the X that's inactivated, then the only X that's active is making non-functional or maybe no dystrophin protein. Now, if there is just little pockets within the muscle cells, some that have the dystrophin and some that don't, the dystrophin that the cells that have the abnormal dystrophin often die off and hopefully are taken over by the normal cells. And so possibly in the muscle, we're seeing actually non-X inactivation because only these, the cells that have this as an inactive X are the ones that are primarily populating the cells. However, there was a very large group of X inactivation where this is the X that's inactivated. There can be certain muscle groups that do have weakness in females. And while 70% of females have no muscle weakness, some do show signs. The problem actually arises in the heart. Women that carry one non-functional copy of this gene actually do have a significantly higher risk of dilated cardiomyopathy, often later than even in the Beckers, usually in the 60s to 70s. But women that carry one copy of non-functional gene for the dystrophin are at significant risk of dilated cardiomyopathy because of X inactivation. The dystrophin gene is actually the largest human gene. It has over 2.4 million base pairs, including 79 exons or coding regions. So management of Duchenne's muscular dystrophy include physical therapy to try to increase muscle strength of the muscle that you have, steroid injections into the muscle to help the inflammatory response to this, cardiac medications to improve cardiac function with the progressing dilated cardiomyopathy. However, research is looking at future therapies, and actually a lot of future therapies are already here now. Something called exon skipping is a method to try to restore some protein function. Approximately 80% of patients with Duchenne's muscular dystrophy have a deletion, duplication, or mutation affecting exon 51. This is a real hot spot here. So if there is, this is normal dystrophin. We have our pre-mRNA and then we splice out our introns and we have our coding region that makes our dystrophin. In a patient that has a deletion of exons 49 and 50, we have a problem because in 51, because of the deletion of part of 49 and 50, there's now a premature stop codon at 51 that results in the stopping of the protein production and no dystrophin protein is produced. So you have no dystrophin, therefore no connection between the actin and the cytoskeleton. However, what if in the pre-mRNA we add something called a PMO? that blocks the splicing between exons 48 and 52. This can actually, we now will not have a stop codon at 51, and we can actually reestablish the reading frame. While the protein will be shorter than we would expect because we're missing exons 49, 50, and 51, we are getting some protein produced. And again, about 80% of patients with Duchenne's will respond to some type of exon skipping. So we're actually making some protein, but it's more like we're changing a Duchenne's to maybe a Becker's. But determining which patients are this can work with means you need to understand where the change is and if preventing skipping here would make any difference. These PMOs are given as an IM injection weekly, and the initial studies are are very encouraging, although it's certainly not a complete cure, and there's still concerns about the dilated cardiomyopathy associated with the Duchenne's. There are other therapies that are also being looked at for the future, but this is actually here now. This is actually a medication that's FDA approved and available for patients that have the right, an amenable change in the gene. So, a 5-year-old male is having difficulty rising from the floor. He cannot ride a 2-wheel bike. His mother has a brother who died of complications of Duchenne's muscular dystrophy. What laboratory study would help make this diagnosis? And the correct answer is C, creatinine kinase. All patients with Duchenne's muscular dystrophy have significant elevations of creatinine kinase. And this concludes the lecture.